It really does make you stop and think. It begs the question, right? What are the real hurdles? And also the ingenious idea is making this kind of care possible.
And not just possible, but truly effective and, importantly, fair for everyone involved. Okay, let's unpack this a bit. Welcome to the deep dive.
Today, we're taking a really insightful look at, well, this expanding frontier of healthcare delivered right at home. We've got a fantastic collection of perspectives from experts in Australia, France, and Spain, all folks who are really on the front lines bringing medical care into patients' living rooms.
Exactly. Consider this your fast track to understanding the ins and outs and the future potential of what's often called hospital at home, delivering essential medical services right where they're needed most.
We're diving into their presentations and also a really thought-provoking Q&A discussion they had afterwards. And for you, our listener, who's maybe keen to get a solid grasp on healthcare innovation, what the patient actually experiences.
Yeah.
Well, this deep dive is specifically designed for that.
Giving you the essential understanding without getting, bogged down in excessive jargon.
Precisely.
Okay, so let's kick things off down in Australia at the MacCallum Cancer Institute. Fiona Winans shared how they're working with cancer patients in their hospital at home program.
And this is where it gets truly fascinating, I think.
Yeah, they've been actively seeking direct feedback from patients using these tools called PROMs and PREMs.
Right. So for anyone who hasn't come across these terms, PROMs are patient-reported outcome measures. They focus on how the patient feels, things like, pain levels, ability to get around.
Their actual health status from their perspective.
Exactly. And PREMs, patient-reported experience measures, look more at the process like, did the care feel timely? Was it safe? That kind of thing.
And what's really insightful here is their systematic way of gathering this crucial information. They use the Promise 29 survey. On the first and fifth days, the patient was receiving care at home. This survey asks about 7 key areas: pain, physical function, anxiety, depression, fatigue, sleep disturbance, even how much pain gets in the way of social roles.
That's quite comprehensive.
It is. And then, when the care period ended, patients filled out a PREM survey. And this wasn't just off the shelf. They actually tailored it with input from their consumer liaison team.
Oh, that's smart.
Really focusing on timeliness, safety, overall satisfaction.
It's a very proactive approach, isn't it? They actually monitor these survey responses twice a day during the week.
Twice a day?
Yeah. And any concerning scores, what they call yellow or red flags, like maybe a pain score of 9 out of 10, that immediately triggers a follow-up phone call.
So it's not just collecting data for later, it's acting on it.
Precisely. It shows a real dedication, I think, to not just providing treatment, but actively listening and responding to the patient's experience as it's actually happening.
And the results, really quite encouraging. First off, they found that collecting this data was definitely doable and really valuable.
The main issues patients brought up were, perhaps unsurprisingly, pain, sleep problems, and feeling a bit cut off from their social lives.
Which makes sense in that context.
Absolutely. But the positive news is they saw improvement in these areas within just 3 or 4 days.
That's a pretty quick turnaround.
It is. And most of the areas they tracked with the PROMs showed positive changes. Feelings of depression seemed maybe one area that might need more attention. But again, not totally unexpected with cancer care.
Right. So the takeaway isn't just they used a survey. It's that a standardized set of questions can really pinpoint the main challenges patients face at home and track how things are changing.
Exactly. And importantly, a large majority, like 80%, felt their overall care was managed optimally.
That's a high number.
And the PREMS results were overwhelmingly positive. 100% reported a positive experience overall. And 93% felt the care was comfortable, safe, easy to access, well-coordinated. They felt listened to and knew how to get help.
Which really raises that important point. How do we maintain that high level? How do we spread it? Well, their next steps are focused exactly on that. Making these measures a standard part of care, embedding them into the electronic medical records, and making sure the clinicians actually see this feedback. So they can maybe even prepare patients better before they go home.
That makes a lot of sense. So building on that focus on the patient experience, let's shift gears now and look at France.
Right. Dr. Marc Potter from Fond Service HAH in France. Now, this is a more generalist hospital-at-home program.
And they brought a really important perspective by looking at quality of life, or QOL, but going beyond just asking if people were satisfied.
How so?
What's really insightful here is that they included not only the patients, but also their family caregivers in their studies. That's the crucial insight from this French study.
Ah, the patient-caregiver dyad.
Exactly. Recognizing that the caregiver's well-being isn't secondary. It's actually fundamental to making home health care work. And often, the caregiver's own health dictates their capacity to provide that care.
That is so critical because, yeah, the focus is usually just on the patient, but the caregiver's experience is absolutely central.
Totally. So they used a questionnaire called the EQ5D3L with 130 of these patient-caregiver pairs.
Okay.
It looks at 5 key aspects: mobility, autonomy or self-care, usual activities, pain or discomfort, and anxiety or depression, plus an overall 0 to 100 rating of their health status.
Got it. And the patients in this study?
Fairly typical for a general HAH program, average age around 72, many receiving palliative care, wound care, some chemo, a mix.
And their quality of life?
Well, as you might expect, the patients rated their overall health quite low, an average of 47 out of 100, and they reported significant issues across all 5 of those dimensions.
Okay, that makes sense. But what about the caregivers? That's the really interesting part here.
It really is. The data they collected is quite eye-opening. Caregivers were, on average, a bit younger, around 65, mostly women.
Common theme.
Common theme. Many were still working, and crucially, about half reported having their own chronic health conditions or disabilities.
Wow, half.
Yeah, and here's where it gets really significant. While their average health rating was better than the patients around 73, a considerable chunk, 20%, rated their own health below 50.
That's quite low.
And almost a quarter, 23%, rated their own health as being the same as or even worse than the person they were caring for.
That's a powerful statistic about caregiver health, isn't it? Really underscores the hidden burden.
It absolutely does. It highlights this crucial point. The health and well-being of those providing care in HAH settings are often really heavily impacted.
So what affects the caregiver's quality of life most?
Dr. Potter's research found, perhaps counterintuitively, that a caregiver's own health had a much stronger effect on their quality of life than the patient's condition did.
Interesting.
With one important exception. If the patient had trouble getting around, that often directly affected the caregiver's mobility as well.
Okay, that makes sense. Physically helping someone.
Right. And the study also emphasized, as you noted, that women and those caregivers with pre-existing health issues were disproportionately affected.
It really just hammers home that family caregivers are essential for HAH programs to succeed. So what are they doing about it in France?
Well, recognizing this, Fond Service HAH established a caregivers committee, and they've developed a comprehensive support system or wellness offer.
What does that include?
Things like help with social, administrative, and financial matters, which can be overwhelming. Respite care to give them a break. Essential. Even practical things like help finding live-in aids if needed. Plus, well-being services, psychological support, even art therapy.
That sounds really holistic.
It is. And what's particularly innovative, I think, is their systematic assessment of caregiver needs right at the point of admission.
So right from the start.
Right from the start. And they've created a dedicated section in the patient's electronic record specifically for information about the caregiver.
That's progress.
And their future aim is to develop personalized care plans for caregivers, similar to what patients receive. It shows a real commitment to this often overlooked group.
It really does. Now, these challenges of relying on family support, as highlighted in France, they become even more acute when a patient simply doesn't have that support network.
Exactly. Which brings us neatly to what they've been tackling over in Barcelona.
Right. Let's look at this unique challenge addressed by Alessandra Martinez Roca from Hospital Clinic de Barcelona. What happens when a patient needs hospital at home care, maybe complex care, but has no family member available to help?
And this is especially relevant for their program providing at-home autologous transplants.
Which involves high-dose chemotherapy, right? So close monitoring and support are absolutely crucial.
Precisely. For anyone maybe not familiar, an autologous transplant means giving a patient very high-intensity chemotherapy, then rescuing them with a transplant of their own previously collected stem cells. It's intensive.
So Hospital Clinic has been running their home care program for these patients since way back in 2000.
Yeah, quite pioneering. But a key requirement, as you mentioned, has always been having a trained caregiver available 24 hours a day.
And they have to live close by, right? Within 60 minutes of the hospital.
Correct. which is a very practical requirement, but unfortunately it meant some patients who were medically suitable just couldn't participate.
Because they lacked that family support, maybe especially those living outside the immediate Barcelona area.
Exactly. So they developed a truly innovative solution, a partnership with a nonprofit organization, an NGO.
That's a brilliantly creative solution coming out of Barcelona. How does it work?
So this program, called Rebuilding Lives, Ending Social Exclusion, started in 2020, thanks to some external funding initially. It's designed specifically to provide professional caregivers to patients who don't have family support.
Okay.
And it's a clever two-pronged approach because it also focuses on improving the job prospects of the caregivers themselves, who might come from situations of social vulnerability.
So it helps the patient and the caregiver. That's fantastic.
It really is. And what's fascinating is how everyone works together. The hospital's home care unit handles the specialized training for the caregivers and selects the patients. The NGO manages the recruitment, contracts, and provides ongoing support and follow-up for the caregivers.
And the caregivers themselves, what are their responsibilities?
A really wide range. They handle treatment control, check vital signs, help with hygiene and meals, coordinate care with the hospital team, and critically, observe for any adverse events or complications.
So, pretty comprehensive care. What's the impact been like?
Really significant. Since 2020, over 50 patients who otherwise wouldn't have been eligible have benefited from the program.
Wow.
And on the other side, it's resulted in over 70 job placements for the caregivers.
That's incredible. A true win-win.
Absolutely. And both the patients and the caregivers have reported high levels of satisfaction. The caregivers particularly value the training they receive and how it's boosted their employability.
It really shows a pathway to address a major barrier, making these advanced HAH services accessible to everyone who could benefit, regardless of their family situation.
Exactly. And it's really encouraging to see that Hospital Clinic is now expanding this professional caregiver model to other complex at-home treatments, like high-dose chemo for other conditions, and even cutting-edge therapies like CRT cell and bispecific antibody treatments.
Shows the model is adaptable and successful.
Definitely. It's a powerful example of tackling social determinants of health head-on.
Okay, so we've looked at patient measures, caregiver quality of life, and solutions for lack of caregivers. Finally, let's circle back to Australia for a different angle.
Right, to the Royal Children's Hospital in Melbourne. This work was presented by Penelope Bryant on behalf of Dr. Elise Horseman.
And their focus was on something really fundamental, yet, as you say, often overlooked. How do we accurately measure the patient experience specifically for hospital in the home, or HIFEF programs?
Exactly. As they rightly pointed out, most questionnaires we use to understand patient experience were designed for the traditional, bricks-and-mortar hospital setting.
Not for the unique experience of getting that care at home.
Right. And recognizing that getting home is often the top priority for patients and families, especially in pediatrics. They set out to create and properly validate a specific tool, the Home Hospital Questionnaire, or HHQ.
Okay, so how do you go about validating something like that? Sounds complicated.
Well, their process was very thorough, following established scientific methods. It started with figuring out what the questionnaire should cover, the content validity.
So what questions to even ask?
Precisely. They reviewed existing research, looked at their own satisfaction surveys they were already using, and crucially, they added an open question to patients. What questions should we be asking you?
Direct input from the users.
Smart. Very smart. This initial work led to a draft HHQ with 6 main areas or domains. Then they refined it using something called a modified Delphi process.
Which means?
Essentially, they consulted with a group of HIF clinicians multiple times, getting their expert feedback, tweaking the questions, until they reached a consensus on the best wording and focus, like getting experts in a virtual room to hash it out iteratively.
Okay, so content validity checked. What's next?
Face validity. Does it actually make sense to the people filling it out? They piloted with 10 families, parents, and kids, asking if it was easy to understand, if the length was okay.
Getting that real-world feedback.
Exactly. This led to some minor tweaks, making the language a bit more inclusive, for example.
Good. Then the really technical part.
Yeah, construct validity. Does the questionnaire actually measure the underlying concepts it's supposed to? They surveyed 134 patients, parents, and adolescents using QR codes and SMS links. They got high positive ratings across the board, which is good. Then they used statistical analysis, specifically exploratory factor analysis.
Okay, statistics.
Right, basically seeing if the questions group together logically. Interestingly, this analysis suggested 5 main areas instead of the original 6.
Why the change?
It seemed that patients saw communication during HI and care coordination. It's essentially the same thing, very closely linked in their experience. So those 2 domains merged into one.
Okay, that makes sense from a patient perspective. 5 domains, then.
5 domains. And the analysis showed strong correlations within those 5 domains, suggesting they were measuring related aspects of the experience effectively.
And finally, reliability. Does it give consistent results?
Yes, they checked 2 types. Internal consistency, that the questions within each domain measure the same thing consistently. They used a measure called Cronbach's alpha, which was generally good, mostly above the standard threshold.
Okay.
And retest reliability. If someone fills it out twice, do they get similar scores, assuming their experience hasn't changed? This was tricky because the surveys were anonymous.
Ah, right.
But they managed to match about 35 patients for retesting based on demographics and found high consistency between the first and second tests. No significant difference.
So while the stats might sound complex, the bottom line for you listening is they went through a really rigorous process.
Absolutely. To make sure the questions actually measure what they intend to measure and that they do it consistently over time.
And the result?
The result is the first properly validated tool specifically designed to assess how patients and families experience HTH and home hospital care, which is a big deal.
Definitely. Did they get any qualitative feedback too, like actual comments?
They did, and that's often where the richest insights are. Things people found unexpectedly good were the level of support, feeling a sense of normalcy despite being unwell, and the holistic care.
Nice.
Constructive feedback included things like wanting more consistency in which nurse visited, issues with visit timing, predictability, and sometimes getting conflicting advice from different staff members.
All really useful points for improvement.
Exactly. And they're already using this feedback. For example, looking into better scheduling software and working on standardizing advice given to families.
That's great to hear. And this questionnaire, the HHQ, is it available for others to use?
Fantastic news on that front. Once it's formally published, it will be an open resource, free available. And there are 4 versions already. One for parents of children, one for adolescent patients, one for adult patients, and one for carers of adult patients.
Covering all the bases.
Pretty much. It's already planned for use in a large multi-center pediatric study across Australia and New Zealand. And they're actively looking for collaborators to help validate the adult versions further.
Great. And you mentioned a website.
Yeah, for those interested, they have hospital-in-the-home guidelines available on their website called Wallaby.
Wallaby. Got it. Okay,
Yeah.
so that covers the main presentations. Yeah. But there was also a Q&A session, right? Any key themes emerged there?
Yes, and it really tied some of these threads together, particularly around social barriers and equity. A really important question came from a social worker in Portugal.
What was the issue?
They highlighted a significant non-admission rate to their HAH program, something like 19%, purely because potential patients lacked adequate family support, often due to the caregiver needing to work.
Wow, nearly 1 in 5. That really underscores the social factors limiting access.
It really does. Mark Potter from France mentioned their government has some initiatives, like temporary paid leave for caregivers, but acknowledged it's often limited, maybe just a month.
Not always enough for a long HA admission.
Likely not. Fiona Winans from Australia added that while flexible caregiver requirements and after-hour support help for adults, having a dedicated caregiver is generally mandatory for children in their HIV programs.
So, different approaches, but the challenge is clearly widespread. Was the gender aspect discussed? The burden on women caregivers?
It was raised. Mark from France acknowledged it's a known issue, the disproportionate impact on women, but admitted they didn't have specific large-scale plans to address it yet, though it's something they're considering.
Which again highlights the importance of that innovative program in Barcelona.
Exactly. That came up as a potential model. Partnering with the NGO to provide those professional caregivers tackles both the lack of family support and creates job opportunities, potentially helping address socioeconomic factors too.
And the details of how that's funded and how the caregivers get trained really sparked interest from other hospitals listening in.
Understandably. It's a very practical solution to a common problem.
And there was another related point from Australia, wasn't there? About training non-medical people.
Yes, about training non-medical individuals, often sourced from agencies, to provide specific care tasks for children with complex medical needs at home. It's another strategy, institution-led in this case, to bridge the gap when family or traditional nursing isn't sufficient.
So lots of different strategies emerging to overcome these practical hurdles.
Definitely. Okay, so to try and pull all of this together, what are the big takeaways from this deep dive?
Well, first, we saw clear evidence from Peter Mac in Australia about how feasible and incredibly valuable it is to systematically measure patient outcomes and their experiences in hospital-at-home programs using tools like PROMs and PREMs.
Acting on that feedback loop. Then, the research from Fond Service in France gave us a much deeper and, I think, crucial understanding of the well-being challenges faced by family caregivers. Their quality of life is critical, but often overlooked.
Absolutely. And we learned about genuinely creative solutions like that NGO partnership in Spain designed to ensure patients without family caregivers aren't excluded from getting essential at-home care. It tackles equity head-on.
And finally, that rigorous work from the Royal Children's Hospital in Australia to validate the home hospital questionnaire. It provides us with a much-needed, reliable tool to actually understand and continuously improve the patient experience, specifically within this evolving home hospital model of care.
Yeah, a validated tool is key.
It really is. So this leaves us and you listening with a final thought to maybe chew on.
Okay.
Considering these diverse approaches we've heard about from Australia, France, and Spain, what do you see as perhaps the biggest opportunity, or maybe the most significant challenge, in further expanding high-quality healthcare effectively and equitably into people's homes?
That's a great question. It really makes you think about the whole ecosystem needed. Supporting patients, supporting caregivers, finding innovative staffing models, using technology. It's complex.
It is. How do we scale these successes and address the barriers systemically?
Lots to consider. Thanks for joining us for this deep dive.